I would like to say thank you to HICS for allowing us to make this webinar possible through a publication grant. Before we get started, there are some facts that I would like to share with all of you. Health providers' efforts in emergencies can make them more susceptible to the development or exacerbation of mental health conditions. After disaster responses, health providers may experience elevated rates of depression, stress disorders, and post-traumatic stress disorder. The sources of stress come from very different scenarios, but some of them are exposure to a scene of human suffering and massive destruction, risks for personal harm, life and death decision-making, intense workloads, and limited resources, and separation from family members who may also be in harm's way. These are some of the resources that we are going to share with you after the webinar has finished. And I would like to get started and introduce our speaker for today's webinar. Sandra Stark-Shields is a disaster program manager for the Los Angeles County Department of Health Services Emergency Medical Services Agency. Sandra has worked for LA County since 2001 and held a previous senior staff position in the County Office of Emergency Management. In her current position, Sandra is responsible for the Disaster Mental Health and Volunteer Program deliverables for the Hospital Preparedness Program HPP grant. Sandra was formerly the Associate Director of Planning and Preparedness and Supervisor of Disaster Mental Health and Health Services for the American Red Cross of Greater Los Angeles. In her previous position, Sandra supervised a volunteer team of 200 licensed mental health and nursing professionals. Sandra is currently the Disaster Mental Health Co-Lead for the State of California with the American Red Cross. And Sandra is a government representative for the California Disaster Mental Health Coalition and member of the Crisis Response Education and Resource Committee for the California Association of Marriage and Family Therapy, CAMFT. Over the past 23 years, Sandra has participated in 22 major disaster operations. Without further ado, I would like to turn this over to Sandra. Good morning, Sandra.
Good morning, Dr. Leon, and good morning to all of you, and thank you very much for participating in this webinar. I really appreciate a second opportunity to present to your group. I really appreciate all of the vital work that all of you do as a part of the National Center for Health and Public Housing. I'm aware that you work with the most vulnerable people in our society, and I appreciate you being on the front line of healthcare and public health. Today, what I want to talk to you about is the second module of the training for preparing hospitals and clinics for the psychological consequences of a terrorist incident or other public health emergency. The first webinar that we did in November, we really walked through disaster mental health from a disaster planning point of view. We talked about the various triggers of psychological consequences of a disaster. We went through a number of tools to help you to evaluate your disaster plan to make sure that disaster mental health is integrated into what you do. Today we're going to, in this module, we're going to talk a little bit more practically or more in the nuts and bolts of once you have those elements in your disaster plan to take care of the psychological needs of your patients and also your staff following a disaster. Kind of what would be the role of a disaster response or disaster mental health within your clinic environment. And I want to give you some ideas on what that might look like that you can adapt for your clinic. I'm hoping all of you can see my screen now. One of the things I want to make you aware of is all of the information that I present today is available on the Los Angeles County Emergency Medical Services website. So if you look at the screen, you'll see what our website looks like. The top arrow is what I look like, so I'm the redhead in the back so that you know who's speaking. Also, if you get into our website, you go under Disaster Medical Services, which it will be on the left-hand side, which will bring up this screen that you're looking at now. And the bottom arrow shows that there's a number of resource documents there that I encourage you to go ahead and look at. Many of them will be useful to you. This training, Preparing Hospitals and Clinics for the Psychological Consequences, or what we call the Psychological Consequences training, is there. All of the slides are there. All the resource materials are there. I want to make sure that you know that if you click on something called resources, if you come into the training today, it has all of the literature that we use to develop this training. So if you want to refer to that, you certainly can. Wanted to just make you aware, as I did the last time we spoke in November, that we developed a number of resources related to Ebola, specifically for clinics, and there might be something in there that's valuable to you that you might want to look at. This is the website address for the EMS agency website for Los Angeles County, and all of the instructor materials are there, and the link is right there in the slides. Please feel free to take these materials and use them. All of the instructor script is there. The only thing I ask, if you add anything to the material, that you change the slide background so there's a difference between your material and mine, and mine and Rand that we worked with. There are some other things that we worked on that may be of interest to you that you can download, use, and adapt. There's a mass fatality planning guide for healthcare entities that we developed. That's for hospitals, clinics, skilled nursing facilities, any type of healthcare facility, and it's a really good, easy to use, easy to adapt plan that you might be interested in. We also developed a Family Information Center planning guide. Again, it's for a broad range of healthcare facilities, and that's specifically for planning to set up an area for family members to wait in a private, especially following a high-profile mass fatality, mass casualty event. And then there's a lot of mental health behavioral resources related to disasters that are posted on our California Hospital Association website. Also, the state of California developed a mental behavioral health framework in December of 2012. The link for that framework is there. The thing that's interesting about this document is that it can be used for mental and behavioral health stakeholder groups. If you have a group in your local jurisdiction that's working on disaster mental health, behavioral health issues, that there's a lot of recommended actions in this plan that might be useful to you when you're looking at planning for the mental health response and mitigation, preparedness, response, and recovery. So I also want to make you aware that this work that we have done here in Los Angeles County is in the context of the Hospital Disaster Preparedness Program. As you know, following 9/11, the federal government began to push out grant money to all states for hospital and clinic disaster preparedness. LA County, Washington, D.C., and Chicago and New York get separate funding also. And the EMS agency manages that funding for Los Angeles County. About 80% of that funding goes directly to the hospitals and clinics that we work with as a part of the HPP program. There are over 100 hospitals in Los Angeles County, and we have about 83 of them that participate actively in our hospital preparedness program. We also work with our local clinic association, the LA County, the Community Clinic Association for Los Angeles County, and there are 33 clinics that participate in that program, representing about 90 sites. So we've been able to do wonderful things with that grant funding that we've gotten, from equipment, training, and all sorts of other wonderful things that I would love to spend more time talking to you about. And certainly if you want more information on that, you can email me, and I'd be happy to direct you to the other things that we have done in terms of that grant funding. But one of the things that we were required to do is to do something related to disaster mental health preparedness for hospitals and clinics. So starting around 10 years ago, they hired me And part of my job has been to work on those disaster mental health preparedness programs for hospitals and clinics. I also run the disaster healthcare volunteer program for the county for the EMS agency. We have 3 different volunteer teams, 2 medical reserve corps programs that are run under the Departments of Public Health and the Health Department EMS agency. We have a hospital surge team that I also run. So they hired me. The first thing that I did was work with RAND to develop this basic training for hospitals and clinics on the psychological consequences of a disaster. And really the point of that training, as you saw from Module 1, had to do with, well, if we were to better manage the psychological consequences of a disaster in terms of staff and patients, what would need to be added to our disaster plan? And then once we have those plans in place, what would our mental health response actually look like? So that's what we're going to focus on today. In the last 6 years, we have spent a lot of focus working with Dr. Merritt Schreiber at UC Irvine Center for Disaster Medicine. We've developed a mental health triage tool here called PsyStart that we use with hospitals and clinics. We've also developed a staff triage and resiliency system, which is a training that I'll talk about too, plus exercise guides and other things having to do with really trying to integrate mental health response with the rest of disaster response and planning. So I won't dwell a lot on PsyStart, but it was developed after this training that you're going to see, and it really has to do with being able to rapidly assess people and address that surge of psychological casualties that hospitals and clinics may see following a disaster. And it's really based on exposure, not symptoms, and the sort of the idea of being that people who are highly exposed to the disaster need a strategy for follow-up that may be different from people who are less exposed or who come to the hospital or clinic because they were concerned, sometimes having some symptoms that they were exposed to some type of substance or what have you, and they actually weren't there. So those people have a different strategy than people who are highly exposed to the event. So that's kind of the idea behind it. It also allows you to map a surge of psychological casualties throughout Los Angeles County. The hospitals and clinics can add the PsyStart data into the system, and then we at the county level will get a view of where the psychological casualties are, and that helps us in our incident action planning for response. And then this is just what the brochure that goes along with the Anticipate, Plan, and Deter training looks like. This is our resiliency training that we do for healthcare workers, where we train our healthcare workers in prior to the disaster on what to expect and encourage them to develop a coping plan. And I'm happy to present that training at another time if you are interested in it. So moving into this training, this Module 2, the purpose of this really is to teach you some skills to integrate the mental health functions within emergency response, and to look a little bit at psychological first aid, though that's not the only intervention that you could add to your response, and really thinking about how do you actually provide some psychological support for your patients, the family member, your family members, your staff. We want you to be able to really understand how to, if you were to develop a mental health response team within your clinic, and we'll talk about what that might look like. What would their mission be? What would they do? Last time we talked about those triggers of psychological consequences. We're going to talk a little bit more about that today in terms of what those psychological consequences actually look like. Talk a little bit about evidence-informed practice and some other tools. So again, we would develop this with RAND in Santa Monica, and also with our partners in it's early in California. the departments of public health and mental health. So we're going to talk a little bit again about integrating that mental health response. It's still true that mental health planning or response planning is sort of still the caboose on the train when it comes to disaster planning. And really the part about that that's so difficult is the fact that mental health is the most enduring consequence of a disaster. And we haven't really done a very good job in terms of being able to identify people rapidly who need follow-up and to really proactively address the concerns of our staff. So that's why you want to overcome whatever resistance there is to integrate mental health as a regular part of your disaster planning, as a part of your disaster exercises and your response. So mental health and medical care certainly can complement one another, and thinking about how that might happen prior to a disaster is what I'm trying to encourage you to do today. So we're going to talk a little bit more about the functions of mental health staff in terms of identifying those psychological hotspots where those consequences, emotional consequences are occurring, and to think about what a response for your clinic might look like. So when you're thinking of, you're setting your priorities in a disaster in terms of mental health, you have to think about, make an assessment about not only the type of disaster, the likely triggers that we talked about last time in terms of restricted movement, limited resources, trauma exposure, limited information, perceived personal or family risk. So you think about where is the area of greatest mental health need. I've been working on disasters for many years now, 23, 24 years, and I always think to myself, I've done a lot of disaster mental health response and leading of SAME, I think about where's the pain? When I think about mental health, where's the pain? Where's those psychological consequences? Where are they occurring? What functions can be performed by licensed mental health staff, if you have any, and what can be performed by other staff as well. So if you think about the psychological reactions and the triggers of psychological consequences that we discussed in the first webinar, and you laid them over your facility to determine where they're likely to occur, that's how you kind of figure out what your response would look like. There's always a risk where people enter and exit the facility, where survivors are being treated, where people congregate. For you as a clinic, that could be the entrance of your clinic, your front desk, any waiting areas, triage areas, staff areas also. There might be some psychological reactions occurring there that would require somebody who has some mental health training to help and assist with. There are other areas that are vulnerable to triggers of psychological consequences. Decontamination and isolation bring their own set of psychological consequences with them. Pharmacy, public information, and anytime you're talking to the press or giving information to your patients about the consequences of a disaster or the health effects of a particular substance that was released as a part of the disaster, there can be psychological consequences there. Your incident command post where you're actually managing the disaster can be a stressful thing. And also, I really want you to think about your phones, because when we're talking about surge of psychological consequences following a disaster, it's not only the people who show up, it's all of the people who call and can flood your clinic with a lot of phone calls, a lot of upset people calling. And you need to at least have a strategy for that on how you're going to manage that, and also the staff areas. So we want you to think about, I want you to think about pre-identifying in your facility some kind of mental health disaster response team. Most clinics are not richly staffed with mental health staff. So you need to think about mental health kind of broadly. You maybe want to call it your reassurance team. It may have mental health staff there if you have them, if you have clergy, spiritual care, some healthcare staff that have are good with calming upset people, some volunteers. Sometimes your security personnel can actually be part of your reassurance team. So you think about if you had to do some mental health response after a disaster, what would that look like? Who could you send? You need to think about that ahead of time to determine the areas of psychological support. For me, that's always the kind of the where's the pain question. Where do you think you might deploy people? Certainly your phones might be a first area of concern, and then people coming into your clinic in your waiting area. And some of you will find, or many of you will find, that you need to formalize a working relationship with a sister clinic. Sometimes you may look out your window and find that there's a mental health clinic across the street that may be willing to partner with you and give you additional staff following a disaster. So think about how you might access mental health staff if you need it following a disaster, and there might be some relationships that you can form there. So issues to consider when placing your mental health staff or deploying your mental health reassurance team is, any place where there might be psychological consequences, where there's waiting family and friends of people who were injured in that disaster, and that sort of thing. And so what does this mental health staff do, or what do they do during a disaster? Here's some possible roles that I want you to think about. Disaster mental health is not an office practice. It's a field-based practice. It's not based on the 50-minute hour. It's much more practical and reassurance and education-oriented. So that's what you have to train your mental health staff to do. They can offer assistance. They can do what we call walk the line. So if you have a surge of psychological casualties there, or a surge of people coming into your clinics, they can walk around and kind of get a feel for what's happening, identify some potential disruptors, conduct some mental health assessment, identify urgent and non-urgent mental health needs. They might provide some early interventions such as psychological first aid. And there should be a part of your hospital incident command, your clinic incident command structure. And we'll talk a little bit more about that. Within hospital incident command, which is what we use in Los Angeles County, the clinics use a version of this, or they've adapted a version of this to the clinics. And if you're interested in that version, I could certainly connect you with our clinic association. But within incident command, there is a position specifically called a mental health unit leader. It's now called a behavioral health unit leader. And that's the person who's in charge of overseeing the mental health response for patients following a disaster. So I really want you to think about integrating that, identifying somebody to be that mental health unit leader prior to a disaster, and have them a part of your command structure. Also, I want to mention to you that there's something called an employee health and well-being unit leader, and that person's responsible for the health and mental health of employees following a disaster. And you really want to identify somebody to do that and to integrate them also into your incident command structure. So if there's one takeaway for you today, it's yes, disasters bring psychological consequences, and you need to integrate and allow for that as part of your incident command. So what does that person do within incident command? They provide that mental health guidance. They provide information on what the impact is that the clinic is experiencing, and that's part of the incident action planning process. They may be requesting and determining how to get additional mental health staff, psychotropic medications, any public communication that has to go out. The mental health issues can be addressed there. And there's also, observing and helping with signs of stress. Again, the mental health practice is mental health by walking around and providing that informal reassurance and being present throughout the incident. Knowing that people are going to have those normal reactions to a disaster and providing that education and support. So non-mental health staff can also do a lot of things. They can provide psychological first aid. They can identify people for follow-up. They can provide brochures on coping. You should identify SAMHSA, the Red Cross, sometimes your local mental health department has usually a one-page coping with disaster brochure that you can pass out, a copy and pass out, many in multiple languages that you can pass out to people coming into your clinic, and there can be one for staff also. Okay, we're going to talk a little bit about psychological reactions to large-scale disasters. The reason I go through this material, most of it you know, is this is a part of your education arsenal. So when you're talking to people about why they're reacting the way that they are during a disaster, this is the information that you use. So certainly in a disaster, we're all going to have emotional reactions. We're all going to have some type of psychological reaction to that disaster. It's normal, expected part of the disaster. Some people will have an intense exposure to that disaster. Some people will develop some issues that need to be addressed for follow-up, but in general, we're all going to have reactions, and they're emotional, behavioral, cognitive, somatic, and some diagnosable psychiatric illness. There's also some spiritual reactions that people can have. So these are some typical emotional reactions, and again, we don't have time to really go into deep depth in all of these things. But the one thing I want to tell you about disasters is that everything that you know about grief applies. Whether you just lost your composure and your peace of mind to losing family members, housing, your community, all the things you're used to, everything you know about grief really does apply to a disaster situation. And the recovery process from a disaster is very similar to the recovery process in grieving. So there are a lot of typical reactions there from grief, sadness, hopelessness, despair, that sort of thing. There are some behavioral responses that adults have. The behavioral responses of children are a little bit different. The things that all of these are sort of expected. The one thing that I really am concerned about is emotional withdrawal. Because people who, and I watch for, not only for staff, but I watch for patients who are emotionally isolated. People who are emotionally isolated have a tough time every day, and during a disaster they really have a tough time recovering because they don't have anybody they can talk about their reactions with. We know from the research that people who are emotionally isolated have a higher an earlier death rate than people who are more socially connected. So that's really a big thing in disasters that I look for. There's behavioral responses with children. Here are some typical ones. The things that parents come to talk to you about have to do with suddenly their child is acting younger than they did before. They're clingy. They have regressive behaviors. Sometimes there'll be a refusal to attend school or daycare, and I've found that oftentimes when that comes up, it has to do with the fact that the parent is not coping well, and that the child feels that they need to stay home and take care of the parent, or somehow the school doesn't feel like a safe place. So these are all kind of reactions that children may have. Self-blame. Remember, children are different than adults in terms of they have an exaggerated sense of self-reference due to their developmental age. And so sometimes they can think that what happened during the disaster was their fault, and so that's something that you can check out. And again, if we had more time to talk about it in this webinar, we'd go more into those, but there are some basic things for you to think about. The cognitive effects of a disaster really have to do with the difficulty concentrating, repetitive thoughts, recurring dreams. All of those are normal. But if they hang on too long and interfere with your functioning, they can be more difficult to cope with and indicate another that they may need some follow-up. There are some body reactions that people have following a disaster, and one of the things that happens is that you may rule out, if somebody comes to you with increased heart rate or palpitation, that sort of thing, nausea or vomiting, the first thing you're going to do is check for the medical reasons for why these things are occurring. And when you've ruled them out, having reassuring patients that that can be a part of that normal reaction that they're having can be very, very reassuring. Some people will have diagnosable psychiatric illness. That's not the majority, that is the minority, and it's for people who were highly exposed to that disaster in general. For typical types of disasters like floods and what have you, the diagnosable new incidence disorder rate can be about 10 to 20%. But for things like 9/11 and some of the much more emotionally difficult, widespread destruction types of disasters, certainly terrorist incidents, then the diagnosable psychiatric illness rate goes up, can be as high as 30%, depending on that type of disaster. Here's the acute stress disorder that you diagnose within 30 days of the trauma. The post-traumatic stress disorder is not diagnosed until 30 days after. Sometimes major depression is co-presenting with it. Rarer is panic disorder, general anxiety disorder, and adjustment disorder. So basically what I want to tell you in a nutshell is for psychological reactions, you expect that everyone will have reactions. It's a normal expected part of a disaster. There's a range of emotional reactions that people have. There are typical reactions to abnormal events. Most reactions will resolve naturally over time, but care needs to be taken for those that may have a more severe exposure to that disaster and may end up needing some referral or experiencing sort of the new incidents of post-traumatic stress or depression or co-presenting. So let's talk a little bit about evidence-informed practice here. So when it comes to early interventions in a disaster situation, those really have to do with their crisis-focused, they're aimed at reducing emotional and mental distress to help people access their coping, their problem-solving skills, accessing their support system, facilitating recovery, and referral, if needed, to mental health professionals and providing advocacy. There are some evidence about early interventions in terms of their early, brief, and focused psychotherapeutic interventions can reduce stress. Cognitive behavioral therapy can be very, very helpful in terms of that helping people resolve those severe reactions to a disaster. And those sort of one-size-fits-all, everybody needs a debriefing, everyone needs psychological first aid. We're trying to move away from that much more to look at what can we do for the general population in terms of education and reassurance. What can we do for people who are very, very exposed to that disaster and may need crisis intervention? They may need to be referred for those brief cognitive behavioral therapy types of trauma-focused CBT, all of those things. They need to be need to be referred to that. So we're really moving away from that one-size-fits-all type of response to a disaster. We don't presume a clinically significant disorder at the beginning of a disaster, and those who are very highly exposed may need some type of referral. Psychoeducational support is really a lot of what you do in disaster mental health, and we really don't advocate doing a lot of debriefings, especially if that's the only thing that you're offering as a way of preventing or reducing mental health disorders. So let's talk a little bit about psychological first aid and talk about the hierarchy of needs in a disaster. When you're thinking about working with people in a disaster situation, you really need to think about first things first. You need to think about safety, survival, shelter, those types of things first before you move up to any higher order types of information, referrals, all of that other stuff. You kind of need to do first things first. The way I think about that when I think about psychological first aid or think about working in a disaster, I think Kleenex and coffee before enlightenment. I think about, you know, Maslow's hierarchy, and that you need to take care of those lower needs first before you can move up to give people more information and help and assistance. Having them reconnect with their family members, those things are much more important to get done first. So always think about first things first when you're working in a disaster situation. So for early intervention, you really focus on basic needs, food, clothing, shelter. There's some psychological first aid that can occur as an earlier intervention. In Los Angeles County, we use PsyStart, which is the mental health triage tool to determine who was highly exposed and to start thinking about how we're going to manage our incident, both at a facility and as a county, using that information. There is some treatment that's provided, but it's very brief. Usually there can be a referral for a longer-term treatment, and just a lot of information. So just the one provision here is those who have acute stress disorder or clinically significant symptoms should be considered for a referral. They have complicated bereavement. The manner in which their family member died is so traumatic that trauma prevents them from moving forward in the bereavement process. That's what we're talking about. People who have pre-existing psychiatric disorders with current symptoms, people who have been injured in a disaster also will likely need some type of mental health follow-up. And those who experience those intense or long exposure should be offered some follow-up. So we're going to talk a little bit about psychological first aid. The model that's presented here is the National Center for PTSD. I would tell you this: select a model. The American Red Cross has one. The National Center has one. There's the one that we use in Los Angeles County called Listen, Protect, and Connect, which is also on a lot of the federal websites. So pick one. Pick a model. Train all your staff in it. Don't think of it as the only thing that you can do during a disaster. We don't want to have that one size fits all, but you should have all of your staff trained in psychological first aid. So pick a model and train all of your staff. Psychological first aid can be performed by anyone. It doesn't require a mental health professional to perform it. The strength of it is its basic information gathering. There's some evidence-informed strategies behind it. It can be used with different age groups and cultural backgrounds and that sort of thing. Okay, the National Center for PTSD does have this training online, and you can take it. So it's a 6-hour training of this particular module on psychological first aid. So here I'm going to tell you what psychological first aid is, but this is not a training for it. You need to take the training, which is about 6 hours. The Red Cross training is about 4 hours to take, and some of the other models can be trained quicker, but generally the message is get all of your staff trained in psychological first aid at least. These are the 8 core components of PFA as the National Center understands it. There's a saying hello part of it, where you look at safety and comfort issues first, helping people to calm down, information gathering, offering some practical assistance, connecting people with their social support, and collaborating services. So In the slides you will see that I've talked about, I've kind of given you an introduction to what each of the steps are, and then because my experience is a lot of people appreciate having kind of what's my opening sentence or what does this sound like. I give you sort of some helpful sentences that may get you into each step. This is the safety and comfort. This is, again, the first things first. You know, this is the Kleenex, the coffee, the shelter situation that you need to get to first before you can go up the Maslow's hierarchy, so to speak. Stabilization really has to do with calming distraught people and giving them an opportunity to talk about what's happening. There's an information gathering about how they were impacted by the disaster, looking at people who might need more referrals, practical assistance. Do they need to have a phone so that they can call their family members and that sort of thing. Connecting with their social support. The way I say this is, in the past when something bad has happened or difficult has happened, who helped you? And they can identify who their social support system. If they come up with no one, then I get a little concerned. That's a risk factor. You can provide a lot of emotional support just by connecting people with their support system and just with yourself. There's information on coping with disasters, those basic reactions that people have. Some of that information we went through at the beginning part of this webinar. Linking them to other services they might need. And that's what psychological first aid is, as quick as I could do it for you. Also, you will see in this training there's a lot of information on specific populations, what we now call access and functional needs, people with access and functional needs. So in this section we talk about children, the elderly, people with access and functional needs. We also talk about people who have a pre-existing mental illness, and we talk about how the disasters might impact them. We're not going to have time to go through each and every one of these slides in detail, but I just want you to think about who would surge to your clinic following a disaster. What kind of specific needs might they have? How would you have to change your mental health response strategy based on some needs that they may have? And so this is really kind of runs you through some things to think about when it comes to access and functional needs. And certainly we want to make sure that we have culturally relevant services, making sure not everybody wants to talk about trauma. There's a mistrust of health authorities. People can be ashamed of getting psychological care, which can interfere of your referring them to other types of services. Some people want spiritual care counseling as opposed to mental health counseling. I'm absolutely fine with that. I've worked with a lot of spiritual care colleagues, and they are really good with helping people to move forward in their recovery. And it can be particularly culturally appropriate. Their disaster experience in their country of origin may be a barrier to present some challenges in terms of accessing services and also understanding what happened and how the disaster response in this country is different, and other things in terms of isolation and quarantine. So that's kind of it on that. Now, we're going to talk a little bit about self-care, and let me say this about self-care. I really think that it's very important in your clinic to think about, ahead of a disaster, doing some type of training about burnout prevention, compassion fatigue. Here in Los Angeles County, we do the Anticipate, Plan, and Deter, where we really walk people through that disaster, what to expect, what it might be like, what they may see and experience. We talk about helping them to develop a coping plan for that and use that ahead of a disaster. I think we need to do better with taking care of our staff in advance of a disaster. We need to understand that they will be impacted, as Dr. Leon was saying at the beginning of this webinar, and we need to have something in place, prior to the disaster. We need to put somebody in charge of employee health and well-being within our incident command system. In Los Angeles County, as part of that Anticipate, Plan, and Deter, we also have a monitoring tool to monitor staff exposure to the disaster. Not symptoms, what they were exposed to, what they experienced. And we use that as a way to inform our follow-up, to inform our incident action plan. So that's the general thing that I want to say to you about stress management. If you are in healthcare, you have to take responsibility for the fact that this work that we do is very impactful. It's very rewarding. It's part of our life mission. And the way that we can best remain fit to serve is to take care of our stress every day, and during a disaster we step it up. So if you don't have a stress management strategy for yourself now, I really want you to think about that, because that has to do with your longevity, not only within our profession, but following a disaster. So in this training, I talk a little bit about burnout and what that's like. During a disaster, there's always an imbalance between supply and demand. We are working long hours. We have a lot of people coming in who are upset. We have less supplies always to give out than we normally would, and that can be extremely difficult. And we need to do things during a disaster that help our staff cope. Not only do we need to train them ahead of time, but during a disaster we need to think about what our workload is like, making sure people have some time off, things that you know, preventing things like letting people know what they're going to be doing in the disaster situation so they're not in there with this unfamiliar work, doing things that they wouldn't normally do. Other things in a disaster in terms of conflicts in the work environment, because the disaster itself is so stressful, social isolation and stigmatization can be something. And we could see how that happened even in the Ebola crisis that we had, where some people were stigmatized because they worked with Ebola patients. And so that can be very part of the stress. Things to think about during a disaster in terms of how to support the well-being and safety in the workplace, how to support your workers, thinking about that and having a system in place prior to the disaster. Even exercising it as part of your disaster exercise, the care of employees, is really, really important. Let's not make that an afterthought. We need to, our medical mission depends on the strength of our workers, and taking care of them is very important. So I really want you to think about that ahead of time. So there's some self-care do's and don'ts that I have here for you. Again, using your stress management that you use every day during a disaster, you step it up. You realize that disasters are extraordinarily stressful. You do what you can to get adequate sleep and rest, nutrition. Using your social support system is very important. Every day and following a disaster, critical. Things that you do for positive coping, like exercise, listening to music, talking, meditation, spiritual care practices, whatever works for you, you need to do that every day. And during a disaster, you need to step it up.
5 more minutes.
Oh, 5 more? 5 more
yes.
for me to, okay. Before we have questions, right?
Right.
Okay, thank you, Dr. Leon. So limiting the viewing of television, that can be very difficult. And seeking help proactively if those reactions start interfering with your joy of life. They interfere with your ability to get up and go to work. They interfere with your ability to enjoy your family. Don't wait. Go ahead and you know, see someone about that, a spiritual care provider. You want to work with your employee assistance program in your clinic to ask them, make sure that they're trained and ready and available to accept referrals from your workers. You particularly want to make sure that you seek out a mental health professional whose expertise is trauma focused. They use those evidence-informed practices in terms of trauma and traumatic bereavement. That's what you're looking for if you're wanting to get a referral. Doesn't mean years and years of couch time, may mean 6 to 8 sessions to really understand what happened, to develop some new coping tools for that exposure to that disaster situation. So if you're not feeling well after disaster, get help. Don't let that, you know, concretize, and the longer you wait, the more difficult it can be. So there's things that supervisors can do in terms of making sure people have time off, making sure that workers are doing what they're trained to do, and that they're volunteer to do during a disaster as much as possible. You have to manage those conflicts between staff and that sort of thing. And providing, you know, that support of people during a disaster situation is really important. You consider staff well-being and decisions. You actively manage your own stress, and you encourage people to manage theirs. You just help with that self-care and encourage that nutrition, time off, that sort of thing. And provide those mental health resources for staff during the event and after is really, really something to think about. There's some information for workers that you can use and distribute following a disaster. SAMHSA has some great stuff. This is older version of the current materials they have on their website. And again, SAMHSA has great stuff for staff care and patient care following a disaster, those typical reactions to a disaster. And National Center for Child Traumatic Stress also. Red Cross is not up there, but they have great stuff. So if we were together in a room where we could talk to each other more proactively, I would go through these with you. But I want you to think about, you can access these materials and look at them, but I want you to think about exercising, a surge of psychological people who have who are coming to your hospital or your clinic after. There's a surge of psychological casualties. What would that look like? How would you respond? And so this is kind of an opportunity to practice that. So again, you can take this training and give it yourself, and having people go through the what ifs and how they might respond, I think, is important. Here's something from Pandemic Flu. So here's my final thoughts, and then we'll go to questions. These are the main takeaways from this webinar today that I want you to think about. I want you to add one or more mental health professionals to your facility disaster planning team. If you don't have a mental health professional on staff, then you have to have somebody who has that mental health kind of awareness, that they can bring that to the disaster planning process so that you make sure that mental health is integrated. Pre-identify one or more staff, mental health or clinical staff, that can take those positions in incident command. Employee health and well-being unit leader, behavioral health unit leader. Make sure that they're integrated. Make sure you practice during a disaster drill, that position is integrated into your incident command. Think about what this disaster response team, mental health response team might look like in your facility based on what resources you have, and to include a surge of psychological casualties in your annual exercise program. So one of the ways you might estimate that, if you look at the literature, there's an average for each one person who is actually injured during a disaster, 4 other people tend to surge to the hospital. So you could actually think about that when you're doing your scenario, that there's this number of injuries, and I'm going to multiply that by 4, and those are the psychological casualties who are going to come in who don't have a health concern, but they have a mental health concern, so I can practice my mental health response. So that's the end of what I have to present. So I think we can go to questions now.
Thank you very much, Sandra, for this outstanding presentation, and thank you very much for sharing your expertise in the area of emergency preparedness and mental health. If you would like to ask Sandra a question, please submit it through the question box on your control panel. And if you are dialed in through your telephone and would like to verbally ask the presenter a question, use the raise hand icon and your control panel, and your line will be unmuted. You can visit our website, the National Center for Health and Public Housing website, where you will find webinars, monographs, provider and resident center fact sheets, training manuals, newsletters, and information on our annual symposiums. You can also find information on how to contact our talented staff and get one-on-one training. You can also join our mailing list and receive HICS updates, Medicare updates, funding opportunities, information about senior programs, and resources and other resources and services, and information about our webinars. You can also follow us on Twitter and subscribe to our YouTube channel. Right now, Sandra, let me see if there is any questions. And okay. There is, the very first question is, do mental health providers for disasters receive cultural or spiritual training also?
There are some core competencies for people who do disaster mental health work, and there's a variety of trainings that people should take. Even if they're not a part of the Red Cross mental health team, the Red Cross fundamentals of disaster mental health, that's a really good training. The cultural competency is a part of that proficiency. Now, mental health response is different than spiritual care, and so spiritual care providers in a disaster should also have specific training on how spiritual care in a disaster is different from the normal work that they do. Many mental health providers, especially in the Red Cross, are used to working with spiritual care providers in a large disaster, and it's great if you can partner with a spiritual care professional, because many times, especially in like plane crash disasters and things where there's been a lot of deaths of family members, it's great if you can have your sort of spiritual care counterpart to work with the family on not only the mental health but the bereavement aspects of it. As part of our mental health triage that we do with SciStart, we have some specific items where there's been loss of family members that we might refer directly to the chaplain because that's their area of expertise. So.
Great. Thank you, Sandra. And the next question is, what can providers living in a disaster-prone area do beforehand to reduce the likelihood of burnout and stress after a disaster?
Well, I think the way to increase your stamina in working in a disaster situation really is to, again, have really good stress management skills. So, you know, I've been in the business almost 25 years. I regularly do things consciously for my stress, going to the gym regularly, all of those sort of positive things that you can do. I think that you have to practice those every day, and during a disaster you have to also maintain that schedule as much as you can, because that increases your endurance. My experience has been that people who don't practice stress management, they leave our profession early. They're running the sprint, not the marathon. So the way to remain fit to serve, to be able to provide that critical patient care during a disaster, really hinges on stress management. The other thing is that I'm trying to, I hope, give you the message that employers have a responsibility to help their staff to cope better, to realize that they're going to be impacted by that disaster, to have training for them, resiliency, mental health resiliency training in place, to have a method of overseeing staff mental health during a disaster, to provide some follow-up based on people who have been extremely exposed to that disaster, beyond a debriefing, beyond a little psychological first aid. You really need to think about that more deeply because we owe it to our workers to help them to endure a disaster situation better. And so think about what that might look like. Think about how you can dial that into your incident command. Think about talking to your employee assistance program prior to the disaster so that you know what they can and cannot provide for you in terms of assisting with follow-up for staff.
Great, thank you, and excellent response, Sandra. Our next question is, if a person involved in a disaster refuses mental health assistance, but you see that it's highly necessary, what would you do?
Well, I think my approach tends to be is I don't kind of go boldly into a referral. So I talk about the disaster first. I go into that education piece in terms of typical reactions. I try to normalize that. I try to make sure that they know that all of us are experiencing that. I try to talk about, you know, if these are the things that can happen, and I try to talk about, you know, how they're interfering with that person's functioning and joy in life. And then I talk about what that referral might do. It's not like a typical type of, you know, referral. It has to, you know, focus specifically on the trauma of that disaster, developing tools. So I try to explain a little bit more about what we're talking about here. It doesn't mean that they have a disease or an illness. It means that they were really impacted by that disaster, as anybody would be, and that they could use some other support. If they refuse mental health care altogether, I might say, why don't you go to your doctor and talk about how you're experiencing, you know, what you're feeling. Maybe the doctor has a way in that might help, or they'll take the referral from the doctor, not from me. And if they don't want mental health care, then my next thing is spiritual care. I try to see do they have a spiritual care provider? Would they be willing to accept that referral from a spiritual care provider who could maybe help them with those grief reactions, who can help them with recovery, who can help them with a positive context of why bad things happen to good people and how they can move forward. So that's what I do. It doesn't always work, but I try to provide a context of why the referral could be important. The other thing, too, is that, you know, making sure that you have something in the community, like a general, sometimes we have, after a disaster here, we'll have community meetings where a lot of people who are appropriate for that community, you know, there'll be spiritual care leaders or maybe mental health leaders, can talk about the disaster, can talk about those reactions. And within the context of community and within the context of that particular culture, that can be a good approach first before you kind of go into a referral in cold blood, so to speak.
Great. Thank you for that answer, Sandra. And we have two more questions. The next question is, are there any recommendations to assess the mental health status of healthcare workers before an emergency?
The mental health status of healthcare workers? I'm struggling with that one. Other than what you would kind of use every day, there are some people, let me say it to you this way, you know, you always have to be monitoring the coping of your staff, not in a stigmatizing way, but, you know, just helping them to realize that, you know, their stress levels every day can interfere with patient care. So everything that you're doing for staff care now, employee assistance, I think you need to continue to do that. There will be some members of your staff who are not appropriate for disaster work. Not everybody is good in that situation, so you have to think through who you have on staff. and what they might be able to do in that disaster that would be more in line with something that's comfortable for them. You should inventory your staff in terms of who lives close, who lives far away. There are some people giving them a disaster mission if they live an hour or so away, 2 hours away, or that they're in charge of the sole care of their elderly parent or their children, that they may not be able to assist you as a part of your immediate response. So that can be, even though it looks like you're looking at people's location, it also, their location has an impact on their coping. So use what you do every day to support the mental health of your staff. Think about what they might do, your staff might do, what their roles could be in a disaster, and whether or not that's something they're comfortable with. Using those disaster exercises so people feel familiar and comfortable with their role is another part that you can do to support mental health with your staff. And then, providing that follow-up care. As part of our clinic, we believe in stress management for our staff. We believe that we need to help you following a disaster, and these are the things that we're going to do for you. And this is a system we have in place to assist you. I think that's a more proactive approach than we're going to have disasters. I hope you can cope with that all by yourself. I just think we just need to have a more institutionalized way. And if it's an expected part of the clinic environment, then that's less stigmatizing, I think, as well.
Great. Thank you, Sandra. And there is one more question. Before we go to that question, I just want to remind all of our attendees to please complete the post survey. The pre and post surveys help the National Center for Health in Public Housing to improve our webinars. The last question that I have for you, Sandra, it seems that you answered part of the question, is how many mental health specialists would you recommend to have in an emergency preparedness team?
Well, I think you want at least one if you can have one. I know that a lot of people are not richly staffed. Even in a hospital situation, they're not richly staffed. But I would just try to go for one. And then I would think in terms of how big your clinic is, what the surge is likely to be. You can think about what the surge has been in the past of people showing up when they're, upset, but they're not necessarily have a physical need, and think about ahead of time about how many mental health staff you may need for that based on the population you have, the language needs that you have. So a bigger clinic, you might want to have more than one. And then you use your mental health staff for the more difficult situations. So when people may need crisis intervention, or they may need a referral, or there's somebody who has come in and they're threatening suicide, or that sort of thing. You want to save your mental health staff for those kind of missions. You want to make sure that there's at least one mental health staff who's aware, who can maybe be in the incident command, and then have other people on your team who can handle psychological first aid, who can handle information, who can handle handing out brochures, who can handle difficult phone calls. So think about not only how many you may need, the partition of duty that will help you to be like a force multiplier in terms of mental health. So that would be my advice. I mean, the more the better, but try to go for at least one.
Excellent. Thank you very much, Sandra. And I want to thank Sandra for one more time for her time and for sharing her experience in this particular field of emergency preparedness and mental health. And if you have any training and technical assistance needs, please contact any of our talented staff members. And once again, I thank you very much for attending this webinar, and thank you, Sandra, for your presentation.
It's my pleasure, and thank you so much for inviting me.